Okay, happy Monday, everyone. Excited to be here with Austin, who's running a little bit behind, but will join us here shortly. And you always look forward to this month together on these Mondays. And shout out to Krishna and Sambhavista that are doing describing the teaching points. And Manaswini has a case. Manaswini, do you want to kind of introduce yourself for those who don't know you by now? And yeah, then we can get the whiteboard shared and get started.
Hi everyone, I'm Manuswini. I'm from India and I'm presenting a case today. And I'm really excited to be presenting to the master educators of CPS who are just so encouraging. And I feel incredibly lucky for the opportunity to learn from them. And I'm really excited to be presenting today.
The excitement is all ours. And then, yeah, Austin's here. I think we're both on service, so both hanging out. But yeah, somebody said Sambasiva. Sorry, I keep mispronouncing your name. I
Yeah,
apologize.
I'm Siva. Hi, everybody. I'm excited for the session today.
Thanks, Siva.
Thank
And
you.
then Krishna as well.
Hi, Alec. Hi, everyone. I'm Krishna. I'm doing teaching points today. I always love Manaswini's cases, and I'm excited.
Okay, amazing. Maybe we can get the whiteboard shared and we can get started. Um, all right.
Um, all right, so here goes the first aliquot. There's a 56-year-old gentleman with right flank and lower back pain for 2 months.
Okay, Austin, this is sort of your wheelhouse. You want to go first?
Yes, no problem. And I apologize to everyone for my tardiness. I got stuck in a close of care conversation, but so thank you for everyone's patience. So right flank and back pain for 2 months, and a young person, or excuse me, a middle-aged person. And Monty, was it 56 or 36?
Yes, it was 56 across.
56. Okay, sorry, I misheard. 36. So middle-aged person having right flank and low back pain. So I think there's many different ways to approach it, and we've talked about on VMR and sort of the academy space many times about back and flank pain. And so I think I will probably keep it brief and go with more of a statistical and base rate approach than really to do anything else. So quickly, in a middle-aged person with flank and back pain, I think the flank pain for some reason gets translated to like we sort of approach a unique way, like, oh, it's a kidney stone, which I think is like a lot of type 1 thinking for people. But if you reflect in real life about people when they put at their flank, the flank is right next to the back, or is the back, when you ask the patient to clarify what's going on. So I would say that I don't really approach the two things different from one another. And that might be, mistake when we come back to reflect in the end. But I would say in my experience, I don't really, I just ask people to sort of point to where the pain is. And if it truly is more like lateral, then, that could pull me away a little bit from the back. But so much of radiculopathy can occur on the lateral aspect of the thorax as well, that I really don't translate that into too different a problem at this point in time. The one thing that, sometimes we'll get into the trap of doing, and Manaswini did a nice thing of clarifying, is that people will talk with you, say, I'm having flank and back pain, and we automatically translate it in our mind to say that the patient has low back pain. But if the patient has the pain that's more of like a thoracic type pain, or sort of more closer towards their shoulder area, then that really influences the probability of this being sort of a degenerative or musculoskeletal disease. And so I think the power of it saying that it's low back pain keeps us into the base rate versus not. And so I think that's powerful election. So I'd say, what are the things that we need to solve very quickly to make progress on? And I'd say, as Robbie has reflected to us before, it's like, is there inflammation in this person, either because they have overt inflammation by history, or they have a significant vulnerability in the form of immunosuppression, or they have having hardware in their body, or they have sort of engage in activities that could predispose them to developing infection, like IV substance use, and a history of malignancy. Like outside of those things, and then of course, like the focal neurological findings. If you sort of go through those 5 different buckets, you can go pretty quickly into saying, hey, can I just stop and take a deep breath and actually conduct the history first, or should I stop my history and just go straight to my physical exam? And I think in real life, oftentimes you'll do your exam while you're actually eliciting the history if you're trying to be as efficient as possible. But at least for the way I was taught in medicine, it's like, hey, I'm going to sit down and get this full history. But if the patient tells you early on that they have like numbness and tingling in their leg, stop the history that you're doing and do your physical exam to see if you find a focal deficit to corroborate that. Because you could ask all the history in the world, but the patient will need to be re-triaged to, if they're not in the hospital, to go there to get imaging the expedited way. But yeah, Alec, I'll pass to you to reflect before we receive the next Alec.
No, excellent reflections as always. So no, I think something that comes to mind for me when I see this, complaint, and yeah, I agree with Austin. Like when people tell me flank pain, I usually just ask the patient, like, if you had to point to me in one spot where it hurts, could you show it to me? Because like I have people with flank pain, they point to their spine, right, or they point to their like mid-axillary line, right, or they point like right below their ribs, more anteriorly. So it's a little bit different for everyone. And then low back pain is so common that like first pass is just MSK, but the things that came to mind for me is like how life limiting or sort of mobility limiting is this? Is it worse with like movement or not? How's it been affecting the patient? And then I think the arc of the symptoms, is this static or is this progressive, right? Is this intermittent? Is this more constant and progressive? And I think those sort of qualifiers would really help us. And then I think the presence of inflammation is super helpful. The presence of any sort of focality of weakness or other associated symptoms. And then I think the immune status of the patient. All of those things are going to influence how we, build upon this. But I think as base rate, like right lower flank pain and back pain for 2 months, let's say this is sort of non-progressive, right? This is just like MSK back pain until proven otherwise, right? So I think it's where the additional qualifiers in the background, more of the clinical syndrome, and if the patient can really sort of inform us about how much deeper we need to dive into this. So I think I'm going to stop there, and yeah, Manaswini, would love to hear more.
Awesome. So here's to giving more background to the presentation. So 2 months prior to the current presentation, the patient woke up with right flank and lower back pain, 4:10, and he described it as achy and burning and radiating to the buttocks. And the pain worsened with prolonged sitting and movement and did not improve with bending forward or lying down. It was associated with numbness of the left leg, and he goes to see an orthopedist, and he has a normal x-ray, so he's prescribed diclofenac and he's discharged home. And the pain is intermittent and was partially relieved on medication, so he just assumed that it would get better. But 1 month prior to the presentation, the pain becomes persistent and constant, and there is this progression of numbness from the left leg, and also there is some weakness that is now involving both the lower extremities, left more than the right. And he revisits the orthopedist, and the workup is unclear, and the only additional management he gets is an abdominal brace. So in the current presentation, he's brought in by the family due to the progressive decline, and he's wearing the brace, and he reports new numbness in the groin while urinating, but he denies urinary urgency, retention, or incomplete bladder emptying, or any bowel and bladder incontinence. He denies trauma, and he says that he can feel his belt at his waist. He's not very clear about that. But functionally, he's now able to he now ambulates with a cane at home, and he uses a wheelchair for longer distances, both of which he did not require 2 months ago. We do not know his sexual history, and his past medical history is hyperlipidemia and hypertension. He's on hydrochlorothiazide and diclofenac and tizanidine, which was prescribed for the pain. There's no surgical or family history. His social history is that he's a contractor and in the plastic and chemical manufacturing industry. He socially drinks alcohol, does not smoke cigarettes, or uses any drugs. And yeah, this is the second Alec Austin.
Wow, thanks so much, Manaswini. What a rich history. So I think this patient breaks the rules, right? So usually when you don't worry about back pain when it's static, right? And or we don't worry about it as much when it's static, I should say. And I think the sort of the functional limitations that this sort of process is having on the patient are profound, right? 2 months ago, working, not having issues, now like can't even walk sort of longer distances without sort of a wheelchair. Is profound. So I think the first pass, the initial pain in the right flank that woke him up. So it seems like maybe it started off as a little bit mild. It's really hard to say if that's hyperacute or acute. I'm going to say sort of more acute. And it sort of comes and goes. Was with radiation to the buttocks, it's like fairly consistent with radiculopathy, lumbosacral radiculopathy, or what formerly known as sciatica. But I think it's the progression here to additional numbness and then weakness. And peculiarly, it seems like the pain is worse on the right, but the weakness is worse on the left, if I'm getting that right, is also peculiar. So I think I would become more and more worried about some sort of process in the lower spine that could be leading to compression initially of the sort of the nerve root, and then now has been making its way down further into the roots near the cauda. But I think a physical exam here is going to be so powerful to see if there's upper or lower motor signs. And so the patient says that he's urinating fine, but I'll tell you in my practice that sometimes when people lose a little bit of sensation, they really lose their ability to tell, like, oh yeah, I am peeing. But like whether they can fully empty their bladder or not is a little bit less clear. So as Robbie likes to teach us, on all these patients, like a PVR is like one of the most powerful tests that you can do in people with back pain, just to be sure that they don't have more kata or sort of cord involvement. So I think the initial history is suggestive of radiculopathy, but the progression of it makes me worried about some sort of process in the spine that is getting worse that we're missing, and the etiology of which could be numerous. No, I guess the patient does have some cardiovascular risk factors. So thinking about, could this be some sort of vascular event? But the distribution, particularly bilaterally, makes the brain a little bit less likely to be involved here. But again, the sort of the neurologic exam, if we pick up other sort of signs of weakness or focal deficits that the patient isn't noticing because other things are more physically bothersome to him, I think will be really, really telling. And then as far as the background, the medicines don't really stand out to me too much. His work in the plastics and chemicals industry is peculiar. I'd love to know which types, depending on where he is and what sort of substances he uses, in his work, could predispose him to different types of cancers or other exposures or other things. Just as a sort of like a type 1 thinking there. So we have a little bit of red flags as far as the weakness and the numbness and tingling. So I'd love to get a sense too if there's any inflammation in the background, weight loss, fevers, chills, other things. And then, from our health-related behaviors, we have some history, but not the sexual history. And we'll have to sort of layer in whether that is going to be relevant, and certainly sort of risk stratifying the patient by their immune status and figuring out if they have risk factors for HIV, I think would also be particularly important, just how that might frame our differential here. So, Austin, I think here I'm getting sort of a flavor of radiculopathy that's progressive. And we'll have to see kind of where that localizes. And then I sort of layered in the background history as I thought best, but I'd love to hear what your reflections are.
Yeah, beautiful distillation. I think I'm going to challenge myself to try to do the localization exercise, and then also how the time force can maybe influence what we think the differential diagnosis is. So I say, if you ask yourself, what's the most common cause of a potentially like a focal neurologic deficit that's not progressive in this way, but that we would just see sort of statistically speaking, I'd say it's some sort of anatomical issue. The most common one we would see is like a disc herniation or degenerative changes of the spine. But if you ask yourself, as Alex said, those things are mostly static, or when they start to happen, they don't really have this type of progression or this level of bilaterality. And so I think instead of just invoking radicular symptoms alone, I think we're saying that there seems to be cord involvement. And it'll be curious to reflect on that as time goes on. I think, and then I guess it was unclear to me if they had mentioned that he might have a sensory level like at his belly button, or that if like he felt his belt fine. But once we start migrating to have paresthesia as posterior towards the groin, when he's urinating, which I'm not sure if that's just like a pressure or anatomical phenomenon that's happening to where it'd be like intermittent, or that's just like how he notices it when he uses the restroom and maybe positions his body a certain way. But I start to wonder if he might have disease in his thoracic cord that manifests with sort of nonspecific symptoms initially, and then had a radicular component, as you mentioned. And then now we're starting to see the sequelae of that because we've hit at least the motor neuron aspect of this, but we also know there's sensory disturbance as well. So I'm curious to reflect on that. I think if we then challenge ourselves, and I'm wanting to pull up, I don't have access to it, but the neurolocalization exercise based off time course that's on the CP Solver's website about, what buckets can we think of? I would say that, because it's not hyperacute, we're not really going to think of vascular electrical phenomenon, at least we can pick up right now, and probably wouldn't have this progressive time course. Metabolic disturbance can have any time course, but this would be a unique thing for me. And then the structural, again, I think there could be a structural disease that happened, but it's not going to be the base rate structural disease unless you would invoke the possibility of cancer. So that would be interesting. A pre-existing like meningioma or something like that, I suppose maybe if there's expansing or change, that would be interesting phenomenon. What other thing? If I think of like a primary like demyelinating disease of the CNS, I can't say that I would picture it in this way, but I think it does potentially fit into this time course. And then infection would also fall into this. And so, as you mentioned, if we learned that the patient of HIV, that would profoundly influence how we would think through the problem. But in and of itself, unless the time course would be off, unless you think he has like tabes dorsalis or something and he's falling down and everything, I don't think that's going to be at play. So really curious to learn more, and I'm trying to challenge myself. And as you can see, this is my weakness, but I think I'm localizing at least in part to the cord, and then trying to think through, is there an anatomical disturbance that breaks the base rate, or is this something that's more microscopic? And I'm curious to learn more, so I'm excited to hear next what happened next month.
Amazing discussion. So here comes the third aliquot. The review of systems, there's no chills, fever, weight loss, or cough, chest pain, no headaches, loss of consciousness, hearing impairment, or swallowing difficulties, or spasticity and stiffness of the limbs on walking, and so on. And on the physical exam, his vitals are stable. Constitutional the exam, on appearance he's alert oriented ×3, not in any distress, normocephalic, atraumatic, intact extraocular movements, and cardiovascular, pulmonary, musculoskeletal are all normal, and the pulses are normal, well felt. Abdominal, there's no organomegaly or CVA tenderness, but there's some tenderness in the lower back. So coming to neurological exam, there's speech is fluent, intact, naming, repetition, comprehension, cranial nerves are intact, there's no RAPD, normal visual field. Now coming to motor exam, so it's 5x5 in both the upper extremities, but in the lower it's 4x5 in both the lower extremities, both proximal and distal. In reflexes, it's 3+ in the right knee and 2+ in the left knee, and the ankle reflex is 2+, no clonus, and 2+ in the upper extremity as well. Tone is normal, no spasticity. Bilateral plantar reflexes are flexor, and we did not do a per rectal exam to check the anal reflex. Sensations, sensory exams, so sensations are intact, but he states that there's numbness in the bilateral lower extremity involving his lower abdomen, particularly below the L3 dermatome. And he says that, to clarify, he said that he was able to feel his belt, but the sensations were intact, but he still felt numb below the L3 dermatome on exam, a normal balance in gait, Romberg's negative, and on EM coordination's normal. On EMG, there's incomplete recruitment, but there's no other motor or muscle abnormality. So I would like to know what tests you want to get, and then I can proceed with the next aliquot.
All right, thank you so much. And I actually don't know what reduced recruitment or lack of recruitment is, so Alec can look that up while I'm talking, and we can learn more just to see if we need to incorporate that into our problem representation. But I think what we've done is we've corroborated basically what he told us on our on his sort of history and exam, was that, hey, I'm not able to, my legs seem weak. I'm having to use a cane now to ambulate. And so his strength being 4 out of 5 in the bilateral extremities is consistent with that. The reflexes I find to be quite powerful because, if this was a neuropathy, a peripheral problem, it would be, it sort of breaks the cardinal rules. So we had to investigate that. But I think because it's been going on for months, I would expect if this was a peripheral process that the reflexes would probably go down. So the fact that we have slight hyperreflexia, I think points again to probably there's something going on at the level of the cord somewhere. The numbness that extends to the L3 dermatome is interesting. And as someone that does a fair number of sensory exams, it's a really, really tough exam to do. And so I sort of stopped trying if it just becomes more confusing than it seems beneficial. But the fact that we're able to get up to the point that you have like a sensory level usually implies something significant. And then reflecting on cases before, like because you have a level, usually the disease that's occurring is happening above that level. So again, if we think about anatomically, again, I'm worried about sort of like the upper lumbar, lower thoracic cord. It's difficult because a lot of reflexes of the thoracic spine, like we don't test because they're more nuanced, and I don't really know. Most people don't know how to test them, and I'm not sure about their performance characteristics. But that's an interesting reflection. As far as the tone, like it seems normal. And again, tone can be slightly subjective, but there doesn't seem to be overt spasticity. Is that because enough time hasn't passed yet? I would say it seems to be that this has been a progressive process. So maybe it's just that if we unfortunately let this process go on, eventually we would see spasticity and a dramatic change in the reflexes and the toes to be upgoing. If not, does that suggest that maybe the level of dysfunction in the CNS is like slightly reduced? I'm not sure how to reconcile that difference besides it just being either more mild or that it will eventually come. And so I'll be interested to reflect on that later. As far as the rest of the physical exam, some swollen VIP joints in the right hand. I'm not sure what I would do about that in real life. It sounds like the person is a contractor and labor and did hard labor, and the DIPs are like a commonplace for osteoarthritis. So I might wonder about that. The fact that it's asymmetric is interesting. I'm not sure if the patient is right-handed. Statistically speaking, probably they are, but I'm not sure if I'm going to incorporate that yet into my problem representation. So yeah, I think Alec, I've bought enough time. What do you have to reflect on?
Yeah, so according to the Googles and open evidence, reduced recruitment just means like a motor neuron loss, basically, but it's not specific as to the cause. So I think sort of fitting with what we think is going on. I think the exam, I guess, how do I describe this? So I guess really good to pick up the sort of the subtle sort of sensory changes. And like Austin said, usually when we determine a dermatome, which can be really difficult, the disease is usually above. I think so many of the symptoms are radicular, and the cord splits at L1. And so I think the really trying to determine like if the sensory deficits are truly symmetric bilaterally, I think would be sort of helpful, because I'm sort of trying to think to Austin, like, are we seeing sort of like multiple radicular lesions bilaterally, more than one lesion bilaterally, like sort of lower down in the cord. But then that wouldn't explain the hyperreflexia. It would have to be higher up, right? And then, but we're seeing like sort of no Romberg or other sort of like clear dorsal column issues. So some of those other sort of like metabolic or sort of other things are a little bit less likely. So I guess the sort of the sense of how we're going to make progress going forward here is we're pretty sure we're in the cord, at least at this point, right? And it seems to be more so on, at least hyperreflexia seems to be more so on the right than the left, but sort of the determination of the pluses can be a little bit subjective. And I'm more inclined to think that there's, maybe more like one lesion, maybe more that explains it, but sort of going towards more one. But I guess at this point, I'd be thinking about how am I going to make progress. So I definitely want to get the rectal tone. I definitely want to get the bladder scan to see if the patient's retaining urine. I think that would be very helpful to know. And then we have to do imaging at this point. And other things on exam I might look for is if there's atrophy of the muscles at all. It seems like this has been at least subacute. But like Austin said, like maybe we're not seeing tonicity because it hasn't been quite so long, or maybe the process truly was intermittent and then sort of progressed in a way that led to sort of this more acute hyperreflexia, and then later on down the line, the tone is going to increase. So I guess time will tell for us. And then I would love to sort of on exam as well. It seems like the pain is in the back, and like just looking at the back, feeling the sort of the spinous processes, like does the patient have any tenderness? Is there any sort of like asymmetry there? Any particular area that's like more swollen than another, just to be sure if like we're not seeing anything from the outside that may be going in. Typically that's a little bit more difficult, but or if maybe the inside coming out as well, but something I would be thinking about. But I think at this point, at least at where I would be, this patient needs an MRI. And the question is like, where are we going to image, right? And definitely need the T and the L spine. I guess the question I might go back to Austin is like, are we just going to do the C spine at the same time? Cervical spine disease can be so sneaky. We're not seeing anything in the upper extremities. You know, the Achilles reflex is 2+, but so are the upper extremities, right? Is his normal 1+? I think it's hard to know, but we're not seeing any sort of clear, signs of involvement in the C spine. So I think if I had to be picky, I definitely would want the T and the L spine to start. And then sort of the DIP enlargement, I agree with like base rate is probably just going to be OA, not to worry about it. I think there's like some of the bony involvement, there's like hypertrophic osteoarthropathy or whatever, but I usually think that more in the legs and less so in the hands, but I do think it can be in the hands too. That was just like a reflex thought, but I haven't had time to really reflect on that a little bit more. But I think at this point, the EMG, we know the nerves are damaged. The exam confirms that. We're seeing signs of, upper motor neuron disease. And I think the MRI is going to be the best way to try and figure that out next. But yeah, Austin, any other additional thoughts?
Yeah, I think it's curious to reflect on motor neuron disease and hyperreflexia. Yeah, I don't want to put too much talk into that. And then same with the EMG, since I'm not an expert in that. But yeah, I think I get the sense that maybe we could be going into something a little bit exotic. But before I sort of dive into that too much, then we'll just have Manaswini clarify a bit more. So excited to hear the next alpha.
Awesome. So, so in the next aliquot, we perform more imaging and get labs done. So his hemoglobin's 11.2, normal, WBC is 10,000. Hematocrit normal, platelet is 196, electrolytes, LFT, RFT normal, and so the bladder scan was normal as well. It was around 50 to 55 ml. And then there's also calcium was normal, and then we got B12, copper, TSH was normal, HIV was negative, HCV, VDRL, and COVID was done as well, which was negative. And then we also got SPEP, FLC, free light chains, and UPEP, which were negative as well. And then I think his glucose levels were normal. I do not have the HbA1c, but it was well within under 6. And and then his urine analysis was normal as well. Now we did a lumbar MRI with and without contrast, which showed multi-level degenerative changes of the lumbar spine. There was no disc bulging or neural foraminal narrowing. So then I would like your thoughts on, you did mention what to get further, but if you have anything to add before I move on to the next aliquot.
No, thanks so much, Manaswini. So, I think because of the focality on the exam, I think, and I'll have to reflect on this more, but Austin and I didn't really talk about like any of the sort of like metabolic things, right? Or sort of some of the other sort of electrolytes or other abnormalities because the symmetry, I guess you could see with metabolic things, but the sort of the progression of the pain and the syndrome, screams something structural that's progressive. So there's something that's going to be a little bit more macroscopic than microscopic on imaging. So I guess I wasn't really surprised to see all the labs be negative. And I guess that's something in the future I'll have to reflect on if that was that was good reasoning or not. But the MRI of the lumbar spine being sort of unrevealing, I don't know if that was necessarily surprising, just because that we know that some of the features on exam suggest that the pathology is higher up. So I guess I would say, I think that just confirms that, it's probably above the level of L1, maybe. I'll just have to go on a limb on that. But the sort of hyperreflexia and other things just say that we really need the thoracic spine too. And if that's negative, I think that will lead to a really interesting conversation. But I'm really sort of trying to not, I guess how do I phrase this? But I guess overall right now, my thought is this is a patient that has gone from completely functional and in 2 months is in a wheelchair, right? And started out with some pain that was intermittent, some mild neurologic symptoms that has now progressed. So to me, there's something structural that is growing or impinging in the wrong area. And the etiology of that, I think, is a little bit less clear, but would be more concerning for, probably something that's, rapidly progressive. And it seems like the time course is a little bit more subacute for like a hematoma or something like that. So some sort of mass, whether that's malignant or not, would be of primary interest. And I think at this point, I don't really have more to do except to do a thoracic MRI, both with and without contrast to get a better sense of what's going on there. But Austin, yeah, I love your reflections too to see what you're thinking.
No, I think you're right there. And I think this is one of those times that sort of stresses the localization exercise in neurology is really hard. And I think if you haven't already as an internist, you will be humbled by the cervical spine many, many times. And so why don't we just, because the neurolocalization is so hard, like if you've already determined that the person needs spinal cord imaging, like why don't you just do the whole thing and scan the whole cord? And it's really just a practical aspect. Now you can do like a slightly abbreviated version of like a pan spine I learned for the MRI that it happens a little bit more quickly, so they don't have to do as much quality, but at least on first pass you can get a lot of information. But I think practically speaking, whenever you're in this space, it's almost analogous to like, when someone presents with abdominal pain, is it actually in the abdomen, or is it in the pelvis, or is it in the chest? Like, what are the neighbors? And if it was super easy to get like a MRI of the L spine, and then can we include five or six levels above and 5 or 6 levels below? Like we would just go ahead and take care of that because that would really help people make a lot of progress. I think in this case, as you mentioned, like we're concerned about something anatomical, and so if we don't find that, then that's really powerful. Because that will lead us, to search for a microscopic problem or an inflammatory problem. But I think I'm trying to ask myself, like, is there a way that I wouldn't go towards MRI, or is the answer like not going to be MRI? And I can't think of any. But I can really appreciate in real life like how hard it is to do, because I've certainly done it, and I probably will happen to me again where I ordered the L spine MRI and I'm like, well, I didn't show what I want, so we ordered the T spine MRI. And then some rare instances like, oh shoot, I should have gotten the cervical spine MRI. And then you order all of them and they're like, oh, we can't do all of them at the same time. And so there's a lot of practical aspects here, and we should be diligent about the tests we do. But I think in reality, it can be very difficult to tease this out. And so err on the side of doing more than less. So yes, Manaswini, what happened?
Awesome. So I'm going to share my screen, and we got the thoracic MRI with and without contrast. This is with contrast. Would you like me to read what the MRI read? Uh,
Well,
the
I think you gave us the alley-oop of like hovering your mouse during the video of where to look at, so I greatly appreciate that. But I think you can see primarily that in the what looks like the lower thoracic spine, there's a prominent lesion. It's difficult to tell where it originates, but I'm guessing it originates in the spinal body area. But even if it doesn't, it sort of extends in towards like the actual spinous process area, but also into the I think it's extending like in towards at least there's abnormal signal. I don't know if it extends directly into the vertebral body itself. Um, but you can definitely see a prominent area affecting the cord and likely the roots that come out of it as well. And then as the mouse is nicely putting on it, there's some other lesions in other of his vertebral bodies, more superiorly. But please tell me how the expert radiologist actually read it using the appropriate medical language.
oh no, all the expert I see is Dr. Alec and Dr. Austin at this.
Yeah, but I think just to add to what Austin said too, you see those sort of smaller, like, fairly well circumscribed lesions and a little bit higher up in the T-spine. And I don't know if that's T10 or exactly where that is. But you can see this sort of, and looks like it's probably, what is this? Is this T2 flare? Minus me, I guess. So it's T2 flare. So you could see the sort of hyperintensities in the body there, and that it really extends into the spinous process. So it's good to get a 3D view to try and figure out if this is something that's coming from the bone itself and then coming out, or is this something that was soft tissue coming in? More likely, I think, would be to bone out. And then if you really, it's kind of hard to see on the screen here, but if you look at the cord itself, the middle of the cord, around, compared to the rest of it is brighter. So there's definitely some edema there, at least if I can see that on this here. So, I mean, I think from a practical standpoint, based off the symptoms and what that looks like, that's very significant, what looks like cord compression to me. And so the patient needs, sort of urgent evaluation and steroids, promptly, and then to try and figure out what exactly is causing this. So like Austin, I guess to challenge ourselves a little bit. So what are we going to do to try and figure out what is causing this?
Yeah, I love the challenge. I think, as you said, like, where is the problem? And since we have, like, what's going to be more common, like something that originated in and around the cord that metastasizes to the bone, or some sort of disease that affects the bone and then has sort of crosses tissue planes, so to speak. I'm going to pick the latter, just because I feel like most masses like that are within the spinal cord or within the meninges, et cetera, aren't going to be this aggressive. And so I guess I'm reframing the problem, maybe incorrectly, but we'll see, to solve like bone lesions, and then see what I can overlap from there. And then, Robbie has the nice sort of like P's of the bone lesion. So like we already had the paraprotein assessment, a pretty good one, with including a UPEP that was negative. We would check a PTH, though that seems less likely here. PSA, unfortunately, this person is certainly could have prostate cancer, and so that would be something that we would assess. We've checked for the RPR or syphilis, and then what was the last P? I've forgotten. Yeah, I forgot the last P. Alex, maybe you can correct me and tell me what else, what you were thinking.
Yeah, I don't remember the last P. I didn't even remember like probably half of the P's, but thanks for that. I think the sort of the multitude of lesions, and just with the patient's age, and the sort of the rapid progression of this sort of metastatic lesions to the spine, would be, of primary importance. Oh, Paget's, thank you, Menu. And then TB as well for PPD. So the patient, I presume, is from India, but I guess it's hard to know. So I guess what I would be thinking about is, the patient is 56. Are they up to date on their age-appropriate cancer screening? Um, and then as well, really going back to the patient and taking a good review of systems. Do they have any other sort of signal for disease? Um, and I think trying to find the primary site, because this is most likely a secondary site. So trying to find a primary site would be of importance. So I think it's one of those instances where like probably imaging, cross-sectional imaging would be helpful, to try and identify if is there a big lung mass, or is there something in the prostate, or is there something in the bladder, or whatever else. I think at that point, if we don't find anywhere else to investigate further, then sort of direct biopsy of this sort of spinal mass itself would be required. And then also, in this point, you'd be working with your surgeons, like your neurosurgeons or orthopedists, like whoever does this at your hospital, because this patient, at least on my read, like has very significant cord compression. So if you're not going to go in there and do anything about it, if they are going to do surgery, right, they'll take pathology at the same time, likely. So that might give you an answer. But otherwise, sort of practically, you're going to want to be doing, steroids, and then trying to figure out like who is going to get you tissue if you can't figure that out. And then once you do figure it out, like figuring out, is this like a sort of a radiation necessary condition or not, and then sort of being open to like sneaky infections or and other things at the same time. But this patient like can still walk, still has strength. So if there's cord compression there, like time is cord, right? You don't want to be messing around with this. So that's what I would say, and I guess I would love to pass it back to Manaswini.
Absolutely fantastic thoughts and discussion. Um, so coming back, so this was an MRI of the spine on STIR, SAG. I think it decreases the fat intensities. And so there was, Dr. Alec was spot on. It's a T10 vertebral body enhancing lesion, posterior epidural mass measuring 3.9 into 1 at the T10, and there was enhancing lesion with their own blood supply in T3, T6, T8, and T9. So we did do CT abdomen and pelvis to see for metastatic disease evaluation, but I'll come to that in a bit. And I think the other concern was the 5Ps. So we did not get, I think ALP was normal as well, and we did not get PTH done. The RPR was negative, the VDRL was negative, and so we did go ahead and get a CT guided biopsy of the mass, and that showed reactive bone with rare clusters of atypical cells, which show strongly and diffusely positive for S100 and Y-mentin. And this is apparently suggestive of, like how you mentioned, it might be a mass. So it could be osteosarcoma or osteoblastoma and a chondrosarcoma. So I learned that S100 and Y-mentin is positive for clear cell chondrosarcoma. So neurosurgery was consulted, and in the meantime steroids was given, and that significantly improved, not significantly, like to an extent improved his leg weakness. And T10 corpectomy and tumor debulking was done, and T9 to T11 laminectomy with posterior spinal fusion with instrumentation was done, and radiation was started 3 weeks post-operative. And NGS was sent to identify whether he needed chemotherapy or not. I would like to know what further evaluation you want to get, or anything you want to add to this before I go ahead with the NGS results.
I have not a clue, to be honest. I think as we were discussing, it seems like the concern is that there is a tumor that is maybe primarily originating in the bone or the joints or the neurovascular tissue itself, and I don't have a robust illness script or list of those things that can cause that. So I do definitely rely heavily on our pathologists and unfortunately next generation sequencing to help guide about the management. But fortunately, this was identified. The patient received the acute management to prevent further neurological deficits, and then sort of the more definitive management, hopefully with sort of removing the lesion and then stabilizing the spine afterwards. And I don't, unfortunately, that's sort of the extent of my knowledge. Alec, do you know anything more about this?
No, I think it's super interesting. I think a lot of like the sarcomas that I've seen in the past, they're usually like single lesions, like not multiple. Um, maybe that's just my loaded experience. But I guess the S100 is like a trigger for histiocytic disease to me as well. Um, like I think there are some things that are positive there, and so I'd have to be thinking about if there are other like diseases that could be associated with that, and like go back to the patient about their symptoms, and then just sort of understanding, at least up like on my like gross appearance on the MRI, it seems like the lesions higher up in the spine are like consistent with the one lower, and the one lower just seems to be more aggressive for whatever reason. Um, so I guess I would just be going back to pathology and being like, hey, like how confident are we that this is actually, whatever sort of sarcoma it is? And I think the advanced genetic testing can like really help with that. Because the S100 is like, I guess not like slam dunk that it's specifically this like sarcoma or whatever. And then I just asked Jeffrey and Kirtan to like tell me what all the genetic testing means. Um, but yeah, I guess I'm a little bit interested by that. And I guess I don't know, is the fact that Manaswini mentioned the DIP in like a clinical problem solving exercise, is that relevant? Is that not, is that not relevant? Um, and then I think yeah, I think a lot of times, sarcomas in particular on pathology, at least in my experience here, it takes a really experienced pathologist to be able to tell you like what type of sarcoma it is, or like they have to usually send it out. And sometimes the diagnosis can be very difficult to make and to be confident in. So I think I would be going back to them, getting their sense of diagnostic certainty, and then I would be sort of incorporating the genetic test results at the same time. And then just because of base rate, that the idea of like, I don't know if like hypertrophied bone or sort of like degenerative changes over time could like give a similar appearance on the biopsy results. Like multiple lesions in the spine, like most likely to be metastatic. I don't know if the biopsy initially was adequate enough to pick that up. So still thinking and excluding like other primary sites of a malignancy and being sure that these aren't metastatic, I think would be potentially worthwhile, unless we're like super competent in the results of the pathology. And having not seen it myself, it's hard to know if it's like, oh yeah, we got a really good sample, or oh no, the bone was completely destroyed on the way to the lab. So I think those are my reflections. Austin, anything to add before Manaswini gives us more information?
Nope, except thinking through, I think a case that maybe Mengyu, you and I discussed a while ago, like melanoma, because melanoma can just do whatever it wants. So that would be the only other thing to add. So yes, Manaswini, tell us what you learned.
This session was peak clinical reasoning. Dr. Austin and Alec got it in the second Alec cord itself. They mentioned that there's something going on in the thoracic cord. So this patient, we did a metastatic evaluation, CT abdomen and pelvis. There was nothing seen. There was a calcified nodule in the right apex of this on the chest CT, but it was most likely due to scarring. And on NGS, the sample result showed IDH1 mutation, which is seen in chondrosarcomas. And we also got like PSA and beta HCG. I'm not sure how valuable those are. And we also got AFP, which were all in the normal range. And so the diagnosis was clear cell chondrosarcoma of the spine with IDH1 mutation. And I just added the last aliquot for effect if you had any extra thoughts, but this was absolutely wonderful. So yeah, that's the case.
Well, thank you so much for your preparation. It was really expertly presented and organized. And yes, I've never heard of clear cell chondrosarcoma. So fascinating. I feel like in my experience with chondrosarcomas thus far, which is like an N of 2 or 3, it's always like an incidental, accidental finding. The other one I've seen that I can recall off the top of my head is in someone that presented with knee pain, and they thought they thought they had osteoarthritis. Eventually led to an MRI, which eventually led to a biopsy. So yeah, really fascinating. I'm wondering, and I'll have Alec if I can maybe pass it back to Manaswini, if there's like anything that you learned in your reading from about chondrosarcoma that might have led us to get to that diagnosis sooner. But yeah, Alec, before I pass it back to Manaswini, anything else you wanted to add?
No, I mean, just again, like excellent presentation. And yeah, I think this really tells you that even in 2025, how like powerful the problem representation is here, right? Just because of the progressive syndrome here, and like how important the physical exam was to make progress here. Just knowing, you know, finding that sensory level, understanding where the cord splits, understanding, right? Like that if you have hyperreflexia, probably the lesion has to be above L1, right? And that alone, this is really powerful in your workup, because I could definitely see if somebody coming in with these symptoms, oh, it just sounds like sciatica, right? The lumbar spine MRI is negative, and could have just ongoing like have, this was missed, and I've seen it, so I think Austin's like sort of expert in his physical exam and sort of targeting and pinpointing the lesion was critical, and just serves an example to you all about like, it's great that we can plug all this into AI, but it's only as good as the problem representation you make, right? And based on your physical exam skills. So I think there's a lot of value in that. And yeah, like I've seen like one sarcoma, I've never seen a chondrosarcoma. So I'll have to do a lot of reading about like how many times they prevent with multifocal lesions versus single lesions. And whether or not this particular, mutation that the patient has, like was a more aggressive phenotype. And like why all of a sudden the patient was fine and then 2 months later they can't walk. Like, is this something that truly presented more acutely? So yeah, those are my thoughts. Thanks to Andy, Krishna, and Siva for doing the scribing and teaching points. And Manaswini, any reflections or things you wanted to share?
Um, all I want to say is in awe with the discussion and how you described the problem from the first aliquot. And so I did not know whether how it presents, but I learned that it's clear cell chondrosarcomas are rare, low-grade tumors with usually a good prognosis if surgically resected. The patient's doing fine. And it's more prevalent in men. The S100 in type 2 collagen is what is expressed. And if someone presents with IDH1 mutation, it's equivocal to chemotherapy. So this patient was not started on chemo. And this is what I learned. And another important lesson was not just doing the MRI, lumbar MRI, but also get the whole level, because we don't know where the disease is and exactly how exam plays such an important role in that as well. So thank you.
Okay, Krishna, up to you.
First of all, thank you for that amazing discussion, both of you. So what I learned from this case is that in any patient with back pain or low back pain, we should first see, is it a static or a progressive complaint? If it's a static complaint, it usually does not warrant imaging. But if it is a progressive complaint in terms of having neurological symptoms, then we should always think of imaging. And we should also think, is it a focal issue or is it just a diffuse musculoskeletal complaint? And at the same time, is it being referred so that we don't miss other potential causes, especially if it is a flank pain that is being described? We should always think of thoracic causes that can potentially present as lumbar pains. Coming to like the neurolocalization, so in like it helps to think whether this patient's complaints are purely motor or purely sensory, or if there is a sensory and motor involvement. Depending on that, we can think like, okay, can this be an electrolyte abnormality? Can this be related to something which is structural or something which is local within the cord or the vertebral column itself? So In this patient, it was very, very important to perform the neurolocalization down to the level of the lesion, specifically because imaging in this particular patient was warranted, given that he had progressive neurological symptoms, given that he had worsening pain and worsening symptoms in a very short span. And like I think Austin mentioned that this patient's hyperreflexia, his L3 dermatomal sensory numbness, puts the level of lesion above that particular spinal level. So that is something that is very, very important to consider, that when we are suspecting a cord lesion, it is always the dictum that the level of the lesion is above the level of the deficit. So we would want to image the entire spine, either because we don't want to miss a lesion, and for the other reason that imaging just the lumbar spine in this case would have missed the primary cause of this patient's complaints. And in any patient with having on MRI multiple bony lesions showing up as T2 hyperintense circumscribed lesions, Dr. Austin, I think you mentioned like the 5 Ps. I couldn't get the 5 Ps exactly, so I wrote down my own version of them. Like I was thinking like it could potentially be like metastatic, it could be myeloma, it could be myelitis like TB, or it could be a mass. So whenever there are multiple bony lesions, we should always evaluate for a metastatic disease. So we have to perform cross-sectional imaging to rule out other sites of primary lesions. And in a lot of the situations, if there is no other mass lesion that is found, then we have to suspect that the tissue is the issue and we have to go for biopsy. As in this patient's case, the biopsy showed a reactive bone with atypical clusters that were potentially suggestive of osteosarcoma, which is a high grade tumor. And the next generation sequencing confirmed the type and the classification of the tumor. Do you have anything to add?
How can I add anything to that? Krishna, excellent. Thanks again for the teaching. Thanks to Manaswini again for an excellent case. Thanks to Siva for doing all the scribing. And thank you to you all for joining. And yeah, hope everybody has a great day. Take care.